So we will do the top 10 articles on non-invasive respiratory support. I'm looking at specifically hypoxemic / hypercapnic respiratory failure, as well as post-extubation. Number one paper is Brochard, New England Journal of Medicine, 1995. This is the birth of modern non-invasive ventilator. This is the first paper that changed everything. Brochard studied patients with acute COPD exacerbations and hypercapnic respiratory failure. They either got standard therapy or non-invasive ventilation. Intubation dropped from 74% down to 26%, and mortality dropped from 29% to 9%. This is the moment that BiPAP became the standard of care for COPD exacerbations. The lesson is simple. If the problem is ventilatory failure, especially COPD, respiratory acidosis, don't rush to intubation, but you could put on BiPAP. Number two is the Lancet 2000 study, non-invasive leaving the ICU. Does it only happen in the ICU? Well, he studied ward-based non-invasive ventilation. Treatment failure dropped from 27% to 15%. Mortality was cut in half. So it wasn't just a machine. You needed to, you need trained people on the floors to put it on as well. So it's not only an ICU gadget. That's the Lancet 2000 plant study. And then the third trial is the FLORALI New England Journal of Medicine 2015. That's when high flow nasal cannula came on the scene. And now we're looking not at hypercapnic respiratory failure, but also hypoxemic respiratory failure. And the headline was 90-day mortality was lowest with high flow nasal cannula. They compared high flow nasal cannula to non-invasive ventilation, as well as standard oxygenation in patient with hypoxemic respiratory failure. 12% with the high flow nasal cannula versus 28% with non-invasive ventilation, and the biggest benefit was with the more severe hypoxemia. This changed the practice. So now de novo hypoxemic respiratory failure, we start with high flow nasal cannula. The next three studies, we'll look at the ROX index. So how do we know when high flow nasal cannula fails? So the ROX will give us the answer. It's oxygen saturation divided by FiO2 divided by the respiratory rate. So ROX above 4.88 at 12 hours suggests success. A falling ROX should make you nervous. The biggest mistake is not choosing high flow nasal cannula. The biggest mistake is continuing high flow nasal cannula when the patient is failing. Number 5, recovery RS CPAP returns. So COVID changed respiratory failure forever. Recovery RS studied CPAP, high flow nasal cannula, and conventional oxygen. It reduced the combination of death or intubation compared with standard oxygen, and not all non-invasive support is the same. CPAP may help recruit alveoli and improve oxygenation in selected patients. The famous Esteban trial, number 6 in New England Journal of Medicine 2004, is, now we're talking from pre-intubation, now we're talking about post-extubation, extubation failure. So what happens if you develop respiratory failure after extubation? Non-invasive ventilation did not help. It delayed reintubation, but ICU mortality actually increased. So non-invasive ventilation is not a rescue therapy for a patient who's already crashing. Sometimes the best treatment is recognizing failure early and intubating. Number 5, prevent failure before it happens. So what about high-risk patients immediately after extubation? So using prophylactic non-invasive ventilation prevented reintubation. So it went from 24% down to 8%. Timing matters. So Nava Ann 2005, NIV works best when used proactively before respiratory failure develops, as opposed to the Esteban trial. Once respiratory failure develops, then you're better off intubating. Then the 8th trial to look at is Hernandez JAMA 2016. What about high flow nasal cannula? Replacing oxygen after extubation. In low-risk patients, high flow nasal cannula reduced reintubations from 12.2% down to 4.9%, improving comfort as well. Many ICUs will routinely use high flow nasal cannula after extubation, quoting the Hernandez JAMA 2016 trial. And The next trial is high-risk extubation. What about high-risk patients, high-flow nasal cannula compared with non-invasive ventilation? And the important finding was actually that high-flow nasal cannula was non-inferior. Not every patient needs the BiPAP mask. Comfort matters. Therapy patients tolerate is often a therapy that works. So therapy patients tolerate is often a therapy that works is a very good high-yield thing to remember. High wean trial, so this is from the New England Journal of Medicine. Highest risk patients, the sickest extubation patients. So it looked at high flow nasal cannula plus non-invasive ventilation versus high flow nasal cannula alone. Reintubation decreased 18.2% down to 11.8%. And basically, the highest risk patients, you want to combine the strategy. You want to combine high flow nasal cannula plus non-invasive ventilation. That's called the high wean trial. So what are the big takeaway messages? Number one, COPD with hypercapnia, you think BiPAP. De novo hypoxemia, think of high flow nasal cannula. You should use ROX in the clinical judgment. Don't wait until exhaustion. And you should prevent extubation failure before it happens. And it's about timing, the right patient, right support, and the right moment to escalate. In review, we looked at Brochard, New England Journal of Medicine, 1995. Started out with NIV for acute hypercapnic respiratory failure. Plant extended that to the wards. FLORALI in 2015. Now we're talking about non-invasive ventilation. Well, this is high flow nasal cannula for hypoxemic respiratory failure. When to pull the trigger to intubate when you're using non-invasive ventilation or in any of these, the ROX SpO2 over FiO2 divided by the respiratory rate. Then we went over specifically COVID patients did better with CPAP versus oxygenation, high flow nasal cannula, and that trial did not benefit, interestingly enough. Esteban trial, rescue non-invasive ventilation, Nava showing prophylactic non-invasive ventilation immediately after extubation, and then Hernandez trial showing that high flow nasal cannula is a post-extubation support that should be looked at. High risk extubation, Hernandez also looked at high flow nasal cannula versus alternative to non-invasive ventilation after extubation as well. And then, of course, the high wean trial, New England Journal of Medicine 2019, that you add high flow nasal cannula and non-invasive ventilation, and that prevented intubation, reintubation from 18% down to 12%, and that was the bottom line.